tell you, you can see at the bottom, there's a Q&A button. Please use this for typing your questions, and inshallah at the end we will have time to answer all the questions, all the relevant of this part, because it's three parts. So if the question is about other parts and will be then later explained, so it could be postponed to the next parts. So please keep the question for the Q&A button, and the chat is for if you have some issues or you cannot hear, or some problem with the flow of the webinar. And that's all here, and I'll then keep my mic silent and remove my camera, so you can better enjoy the webinar with Dr. Hamasha, Dr. Muhammad. So I'll leave you now with Dr. Muhammad, and please enjoy.
Hello, everyone. I'm very happy to be here. Glad you can join us. Today, we will talk about aesthetic dental treatment with ceramic veneers protocol review. As Dr. Tariq said, it's a trilogy. So part one, today we will talk about how to assess the aesthetic case and the smile design. All right. The next part, which will happen on a later date, maybe about after a week, we will tell you the details. We will talk about preparation and impression. And the last part is the third part, is how do you assess the veneers and how do you cement them, okay? I would like, before we start, I would like to thank Dentsply for this opportunity, and I'm wishing everybody a safe and productive quarantine. Let's start. We will talk about case assessment. So the stuff that we will discuss today are how to categorize the dental aesthetic concerns, how to better understand them. And we have to talk about the ethics and the case selection. And we will talk about alternative treatment options other than veneers. And finally, we will talk about case studying, planning, and smile design, all right? So let's talk about categories of dental aesthetic concerns. Categories of the dental aesthetic concerns, they can be summarized in 4 points: the color, the shape, the position, and the gingiva. Those are mainly the problems that our patients come to correct. And I will give you only 4 examples to make this point clear. This case, we have a patient who is complaining from the shade, the color of this tooth, and the position of this tooth. But the shape of these teeth are good. She's not complaining. And the gingiva is fine. So we have a problem with the color here, and we have a problem with the positioning of this tooth. Next case, we have a problem. We don't have a problem with color, but we have a problem with the position of the teeth. So you can see that the position is causing spaces, but we have a good color, we have a good gingival display, and we have a good, relatively good shape. We can make some teeth wider, but it's fine. That's not the main concern. The third example is this patient. She has an inverted smile line. So she has a problem with the shape of these teeth. They are a little bit shorter than what we can do, what we want to achieve. And we have a problem with this color of this bridge and a little bit of gingival display here. Otherwise, the position of the teeth are excellent. Last example, the shade of these teeth, the color is a little bit dark. We have a little bit of gingival discrepancy, and the position of the teeth, they are a little bit protruded, as you can see, and the shape is acceptable. So these are my examples to help you categorize this problem in your mind. Next, let's talk very quickly about ethics because we don't want to linger. I want to introduce the informed consent concept. We have to tell our patient what he's getting into. We have to inform him, and he has to agree. We have to tell him the expected amount of preparation for his teeth. A lot of patients I see in my clinic, they complain, the dentist prepared my teeth without letting me know or without telling me. Of course, patients' words are not always accurate, but of course we can see that this is a problem because we did not inform the patient. Life expectancy, we have to tell the patient what we're expecting from the veneers. Nothing lasts forever. Don't advertise uh, this nonsense. Alternative treatment options, we have to inform the patient about his options. We cannot tell him, okay, you have to do veneers. No, we have to tell him what are the other options. Even if they are less satisfactory, he has to choose based on his situation. So this is the concept of the daughter test. If you are not willing to do the treatment for your daughter or your mother or your wife, then you shouldn't do it to the patient, all right? Patient's choice, it's always patient's choice. It's not us as dentists who choose for the patient. We just inform them, we help them see the way. And this, in adapting this mentality, you will see the problems in your clinic will drop because it's such an open space and patient will be happy and he will trust his dentist. So we're always aiming for the least intervention that is the most effective in the long term. Case selection, you have to assess patient's motivation. You have to assess his age, his expectations, his level of cooperation. If I see a young patient who wants to do veneers, maybe I will try to talk her out of the treatment. If I see the motivation of the patient is wrong, maybe I will try to dig deeper into this area. Why does he or she want veneers? Why do they want to fix their smile? It's a humanitarian issue, not just drilling teeth and putting veneers. Will I be able to improve my patient's situation? It's okay to refer the patient if you don't have the skills, the lab, or the tools yet. If the case is too difficult for you, divide it into smaller steps and start smaller cases and build your skills gradually, all right? So this is the ethics part. Now let's talk about the exciting stuff. Alternative treatment options. What are the alternative treatment options for veneers? Are veneers the default treatment options? Of course not. We have 3 options instead of doing veneers by default. The first is bleaching, which we will talk about now. If our main concern is the color of the tooth, we can do bleaching. I have to stress this point because bleaching works, and sometimes all the patient wants is a little bush, and they go from A2 to B1, which is a great example for how the bleaching works. And I'm still seeing this patient, and it's still the same shade. He's using the home bleaching, and we used the office bleaching at the first time we did this. If we have the problem with the 4 anterior teeth, 1, 2, 3, 4, and the rest of the teeth are fine. They have good shade, good shape. They don't have a lot of caries, restorations, a lot of problem with their position. And patient just wants to do 4 teeth. We can do bleaching for the rest of the teeth. And you can see here, it's such a drastic improvement that when we put the 4 veneers, it will change the smile drastically. So think about the other teeth. Do they really need veneers or not? Because the 4 concept really works sometimes. Let's talk about this issue which I see a lot of it in the clinic. Sometimes we dig old restorations, old root canals, and we see a lot of old stuff. And this is what's causing the discoloration. So mechanical cleaning for the root canal, the restorations which are poor or old, and the caries. Just the mechanical cleaning with the burr will help you get rid of the discoloration sometimes. And if it doesn't work, you can always go for internal bleaching. And of course, you can cover it if all else fails, right? So when is bleaching effective and when is it less effective? Bleaching is effective when we're at a darker shade with the teeth. If the teeth are A2 or darker, the bleaching will give us a huge difference because the sealing is away. But if the teeth are A1 or brighter, so we're already close to the maximum. So what are we hoping for? So always assess where you're starting with the bleaching and then see if you can improve or not. The discoloration, if the discoloration is yellow and related to food and drinks and age, like coffee, tea, stuff like that, you will get great results. If the discoloration is grayish and related to developmental origins, like fluorosis, enamel, or dentine malformation, you might not be getting the best results you would want from the bleaching, but it's not a bad thing to try. If the teeth are sound, this is where you get the best bleaching because you don't have a lot of restoration on it, so you don't have two colors to match. This tooth is clear. If it's heavily restored, deeply carious, you might have an issue with the composite, with the shade matching. Just a quick point, wait 2 weeks after stopping the bleaching before proceeding with the bonding and the shade matching. Why? We have to wait 2 weeks after stopping the bleaching because the bonding will be stronger after 2 weeks. And the shade matching, you will not put the patient through, you will not choose, let's say, for example, we got a BL4. This is the shade we got after immediately stopping the bleaching. Will the patient be able to maintain this shade? It will be very difficult. So we wait 2 weeks. The shade might go back to A1. And this is where the patient will have easier time managing the discrepancy between the restoration you will put later on and the existing teeth, all right? Home bleaching for maintenance of the results. Always choose, of course, home bleaching because it's much easier and patient doesn't have to travel to your clinic. So we talked about the bleaching. Let's talk about composite, my favorite subject. Composite, let's see. Composite for very large spaces like these ones is less predictable because you have to control the emergence profile. You have to control a lot of shaping on the tooth and angles. It's easier to do it indirectly. So composite is not the best case, not the best treatment for such cases. This is the same patient, and we have much smaller spaces in the lower region, and we can predictably restore it with composite. Of course, do your rubber dam, put the composite one tooth at a time, and you will get predictable outcome if you control everything. So composite, as I said, first point, if you're dealing with a lot of changes, it's not good. This is a case where we'll hammer down this idea. This patient wants to do aesthetic treatment, but he doesn't want to do prep or veneers. So we did some restorations here, and we got a good, I would say it's a good result, but this might have been much better if we chose veneers because we can really change the veneers, the morphology and the smile. But that doesn't mean that, again, patient chooses what's best for him. He will be informed and you will help him decide. Last case for composite, which is perfect for composite. Laterals, big shaped, left and right. We isolate with rubber dam, build the mesial part, build the distal part, and that's it, easy. Let's talk about one more thing. You know, the composite has an advantage over the veneers. It doesn't have an insertion line. If you have an insertion line, an undercut in the tooth, and you place composites, not an issue. But if you have an undercut and you want to put a veneer, you have to prep these sides. This is something to put in your mind, but yeah, just to help you. And this is the right side of the laterals. And this is the final results. Very nice. Okay, so composites. This is an important slide. Take a photo if you want, screenshot, whatever. When is it indicated? Highly skilled dentist, and when access to a good lab ceramist is limited. This is where you go for composite more. But if you or somebody else, not you, somebody else, less skilled dentist, and the access to a good ceramist is attainable. So maybe it makes more sense to go indirect with the veneers, because at the end of the day, we want the best results. So you see where is your limits in the composite and where is your lab's limit in veneers, and you go for what's best. So specific smaller corrections are good for composites, but if you need extensive corrections in regards of shade, shape, location of the teeth, position of the teeth, you will not go very far. And let's compare composite with ceramics. Composite is less stronger, so physical properties are not as good as veneers, ceramic, feldspathic, or Emax. The other point is the visual properties of the composite is less um, attractive than veneers, and you have more time to work indirectly in the lab. So the composite puts a little bit of pressure on the dentist to finish it in 1 hour, 2 hours, it depends. So in the lab, you have all the time to do whatever you want. Of course, it's a less expensive option, and if the patient can afford indirect treatment and it's indicated, go for the indirect. But please don't undercut your price in the composite, because at the end of the day, it's a challenging treatment, and do what's reasonable for you. Patient has moderate aesthetic demands, as we said. If the patient has high aesthetic demands, maybe the composite is not the best thing. In order to master the composite, we need 3 things that I will review very quickly. You have to understand morphology, dental morphology. Working under magnification is very important, and working with rubber dam. In this case, we have a simple morphology problem. 2 centrals, different width. This is a composite, and you can see different width. We fixed it with matching width of the composite. Very easy, just measure the width and you get it. Magnification, you have to, believe me, your work will change once you start getting used to magnification. I see a lot of dentists who are used to their bare vision, and when they work with magnification, they don't really like it because it's a big change for them. Your eye-hand coordination is, there's a learning curve, but stick with it and you will see that your work will be, it's like a different dentist is working because you can see it. I would suggest start with 3.5x. I'm currently using 5x, and I'm planning after this pandemic to go 8x. Hopefully that will not take very long. Microscopes offers greater magnifications. You can see the dentinal tubules in the microscope, but at the cost of mobility, because your loops are on your head. You can go left, right, left, which is something we do a lot in preparations. In the microscope, you have to learn it. It's much more challenging, but it's doable. I see a lot of dentists, they can do it. This is a case that I want to review, rubber dam. Why is it important? And this is a case I did with Dentsply. All the materials we use here is Dentsply, so I'm gonna review them really quickly. Here we have caries, of course, proximal caries. Look at the rubber dam, how it's closed tight around the teeth. And look at the liquidam here, because there's any leakage, just cover it with liquidam. And the first thing we put is any flowable composite. In this case, we used SDR Plus, which has more color options. I like to put the darker like A3 inside, and when I build up with A1, it will give me such a nice color gradient. It will give you a nice natural results. Then, of course, I like to build here and then here. I left this tooth out. Why? Because I have more control over my contact points. So in this case, I used 2 matrices, which is Palodent in this case from Dentsply. They have a nice curve. Just adapt them very well. Build your 2 teeth, then go to your 3rd tooth. Don't do them together. You can do it. I do it sometimes, but I prefer to control it. This is the 3 cases, and I used ceramics Universal Nano Restorative Composite, which is filled with Esthetic technology, which the filler inside the composite is round. So when you polish them, you will not have very rough edges. It will be much better to, you see here, it's a better shine surface, luster surface. And with time, it will hold this luster for a long time. This is about everything about composite. Let's talk about orthodontic treatment. This case came to my clinic. She wanted to do four full veneers, 4 teeth, full veneers. I said to myself, okay, this is a great case for veneers. We will do only 4. These teeth are very nice and they have a nice inclination mesially. So we don't need to change a lot. And the shade is nice, but I want you always to think about ortho. Look at this. Look at the profile of this. You see this tooth? The lower tooth has a deep bite. It's pushing on the upper teeth, and the upper teeth are going forward. Why is this important? Because if I do this this treatment and I do 4 veneers, the patient will surely come back after 1 year or less, and then she will tell me, okay, my veneers are protruded again and there's spaces. So always dig deep in the case, always analyze the occlusion, because you don't want any failures. And also, I don't have to say it, but imagine the preparation that we have to do and the extensive damage if we go indirect. Of course, orthodontic treatment can save teeth from extensive preparation, but relapse is a concern. We have to tell our patients there's a relapse after the ortho. And I see a lot of patients, they come back after the ortho, they give up on retainers and they want, okay, I just want veneers, which is a sad thing because they went through a lot of, months of treatment. Etiologic damage, I see it a lot. Please, if you're an orthodontist, wear magnification loops. Don't take away the most beautiful surface of the tooth, which is the outer enamel. This is everything for the alternative treatment options. Now we will talk about case studying and planning, which is basically digital smile design and stuff like this. So we decided to go for veneers. What to do next? Do we go to the preparation immediately? Of course not, because we have to study the case first. Give the patient another appointment, but study the case first. Why do we study the case? 3 main factors. First of all, it guides your tooth preparation, because after you visualize how your final results will be in the digital smile design, in the wax up, in the x-rays, everything, you get a better idea where the case will go. So you will understand the case better. And also you will uncover the existing problem that you need to address before the aesthetic treatment, like any problems that are urgent or collapse in the bite or anything. And of course, it will inform your communication with the lab and your patient. The patient will see the results before they even start the treatment. Of course, it's a rough estimate, but it's a huge deal. They get to see where the case is going, and they get to see it will help you and your patient and your lab technician. All right. So what do we collect from the patient? Study casts, x-rays, photos and videos, and occlusion analysis. Study casts, just take alginates, put them on an articulator, and you're good to go. X-rays, panoramic, periapicals, check all the teeth, check any problems. Photos and videos, and occlusion analysis. Why are we taking these? Because we want to form a treatment plan and a digital smile design and a wax up, okay? Of course, we don't always do digital smile designs in the simple cases. You don't need to change a lot of things, but when you're doing an extensive change, digital smile design will guide that. So let's talk about photos and videos. Full face, look, we all know, we want full face, front, right, left, smile, retracted, teeth apart, and you want to take the same stuff with the mouth close up. You want to check the mouth very closely. And you want to see the profile. It's very important. Retracted, smiling. You want to take every aspect. And of course, the videos help you a lot to see the incisal display, the smile of the patient, everything. In this case, we have a smile. It's a close-up and the front photo, all right? I always ask the patient to smile the maximum because I don't want to get surprised after I plan and then, oh, the patient can smile with a high lip line. So we needed to do something about that. So always make sure the patient is fully smiling and you don't want to miss any details that are showing. So wait a minute, let's go back. The smiling photo is good mainly for two things. You want to assess your incisal display, and you want to assess your gingival, your upper lip coverage, all right? This side view is also very important to check how the teeth are inclined, protruded, reclined in relation to the teeth, in relation to the face. Of course, I cannot see you the patient's eyes, so we're gonna have all the close-ups on the teeth. This is what I use for digital smile design alongside my other photos. But this is what I want. Why? Because I'm seeing everything. The teeth are not covered at all. So this is the photos you want. So we have a photo and video. Now let's do a digital smile design. I will walk you through the steps so that you don't have to buy any software that costs 100,000 Saudi riyals or something. And of course you can buy those, but I'm just giving you the concepts to plan your cases with nothing but your computer. So you just need a keynote or PowerPoint, take the photo, put it in there, align it, don't have the patient's full face. Of course, this photo has to be full face. You have to see the eyes, the forehead, the chin, because you're looking at the patient and you're planning for the full face. So rotate the photo until you have the best, you don't want any canting. So rotate the photo until it's straight. And then you draw a line here between the eyes or the horizontal. Don't just measure the eyes, check the nose, check the whole face, just check the patient's face because some patients have asymmetrical faces. All of us have asymmetrical faces actually, but some patients have it more than the others. So ideally your horizontal level has to go the same line, just copy it and put it down here. So you have your ruler, you have your reference. And then you want to draw a line where the facial midline is, and hopefully that is not very far away from the dental midline. All right, so this is your landmarks and photo alignment. You put it, align it, everything's good. Next, you go to Google and you just Google ruler PNG. PNG is the format of the photo. You want it to be semi-transparent. Just take this photo, take this ruler, which is a digital ruler, put it over your photo, go to your cast, the alginate cast, remember, we took it, measure this, the incisal length, measure it, and then go from here to this, let's say 9 millimeters, okay? 9 millimeters here, we go, take this ruler, put it here, and try to adjust its size, bigger or smaller, until it becomes exactly 9 millimeters. Of course, one major mistake is some dentists take a photo that is shortened or elongated, so you will not get an accurate result. Just take a straight photo of the teeth, because if you're measuring here 9 and your photo is shortened, it will ruin all your planning, okay? So now we have a calibrated ruler. Now we can measure everything here. But I would suggest take multiple reference points. Okay, we took this, it's 9. We took this, it's 8. Let's see, is it 8 here? All right. Next step, incisal edge location. This is the first thing you want to start with. Every aesthetic treatment starts with determining the incisal edge location. You have the smiling photos, remember? It has to make sense now. Where does the smile line start? It shouldn't be covered by the lower lips. So you don't want the teeth to be touching the patient's lower lips. And it shouldn't be very short, such as this case. This case, I made it 1.5 millimeters taller, 11 millimeters total. So now we have 11 millimeters. That's perfect. Go to the next step. What is the next step? Next step is the width at which makes sense for the optimum results of the teeth. How do you know where to go around the width? If the tooth is 11 millimeters, the width should be roughly 0.87 of that. So 11 by 0.87 is 9.5 millimeters, the width, all right? So now you have the central incisals, you have them under your ruler. You know everything you want to do now. What do you want to do? Go to the next teeth. Next, we will talk about recurring aesthetic dental proportions. This is a little bit complicated, so I'm going to try to simplify it. Each tooth in the mouth, it was found that if you want the most aesthetic looking smile, the lateral is, let's say, 0.7 of the 9.5. So it will be 6.5, okay? The canines is the same fraction. So it's 0.7 of the 6.5. It will be 4.5. And the first premolar should be around that. So 3.5 out of 0.7 of the 4.5. So this is a rough place to start from, but you have to follow the patient's maxilla and lower teeth and face. You cannot go all patients 0.7, all right, 9.5, 6.5, 4.5, all patients. It will not work because some patients have narrow teeth, narrow jaws, narrow bone. And some patients have a really wide smile. So you have to play with this. You have to, all right, let's go, let's say 7 here. So it will be, the fraction will be higher and everything will go distally. So the smile will end here. So I hope that makes sense. And in this photo, you can see that all the distal sides of the teeth will be removed in the final results. Why? Because it's too big. It's very wide of a smile that if we make it longer and we make it a little bit narrower, it will look much, much aesthetically pleasing. So this is the RED proportions. You can read about it online. I'm just giving you main points here. This is an optional step. You can visualize the teeth, check how they look digitally. The fancy programs will give you this functionality much better. And of course, there's 3D planning and stuff that I just want to talk about how I can improve every dentist without really investing a lot of money, just how to start with this concept. This is an illustration that I did in Manchester University to help understand this criteria of a beautiful smile. We have number 1 here, midline. It has to be with the facial, corresponding with the facial midline. Dental midline, facial midline, not a lot of discrepancy. Gingival level, ideally it should touch the centrals and the canines. And regarding the laterals, it can be 0.5 to 1 millimeter shorter. That's okay. And same goes for the premolars, but you know, it's a gray area, depends on the patient. The incisal line, the incisal plane, this is number 3. Also the same, teeth will touch are the canines and the centrals. The lateral can be 0.5 millimeter or 1 millimeter shorter. Some patients like the rabbit look, you can play with that. And ideally, it should be close to the lower teeth without being too much. Patient shouldn't really struggle with the teeth touching his lower lip, all right? For the contact points, we all know that the contact points in the centrals are apical, and they go gradually gingival as we go distal, where they go up, all right? 5, let's talk about the color of a natural tooth. The natural tooth has higher chroma near the gingiva, and as we go incisally, the enamel becomes thicker, and it will give it more opalescence and higher value. What does it mean to have higher value? Brighter. So the tooth will be darker here, brighter here. And we will talk about that in the next part of this webinar when we talk about shade selection. 6, we will talk about here, the 6th criteria is width with the length, the proportion of the tooth itself, and the morphology of the tooth, the line angles, the shape of the incisal embrasures, the gingival embrasures, all of this, okay? 7, and you can take a screenshot of this if you want to remember how to judge a case. 7 is the aesthetic dental proportions, and naturally it corresponds with the buccal corridor. So if we have a proportion of around 70, it will go like this. If you have a proportion, you see this 8.5, 6, 4.2. So each tooth is a fixed fraction of the previous tooth. Okay, that's everything for digital smile design. I hope it was informative and it will help you. I want you to go now after this webinar, go download any PowerPoint or whatever, Keynote, depending on your computer, and just play with it. Take a photo from your old patients. Hopefully you're not seeing any more patients now, and play with this. Digital smile design is a good skill to have. Let's talk about wax up real quick. Now that we have a digital smile design, we know the width, the length, the everything, how much of the gingiva we need to do gingivectomy, cut it from. Do we need to shift the teeth? Do we need to prep from the teeth too much? Now transform that into your wax up. Sometimes I do my own wax ups. Sometimes I let my brilliant lab technician do the wax up. And this helps us understand the case a little bit better. We talk about it. Lab communication is very important, guys. So we talk about the case. Can he do this? Can you do this? No, doctor, I need you to prep from the teeth from here. Maybe we need a lot of thickness because the teeth are discolored. We talk about this, okay? And after your wax up, you can take a simple putty, cut it around, and then you put it on the patient's mouth to check everything you did here directly in your patient mouth. And we will talk about this in part 2, next webinar. We talked about those 3 things. Last thing I want to talk about is the treatment plan, and we're right on time. We still have some time. Treatment plan. Doctor, how do I sequence my complicated cases? Here is your sequence. Take a photo of this. Address the emergencies and stabilize the dentition first. Don't go jump into veneers and the patient doesn't have a stable dentition in the back of his mouth. If his bite is collapsed, address that first. If he has a possible emergency that will erupt later, or he has a problem that you have to address first, don't jump into veneers before it's a good dentition, all right? Let's review these real quick. Emergencies, hopeless teeth extractions and implants. Then we stabilize the periodontal health and the gingival modification. We do them in this 3rd step. Endodontics and restoration, and lastly, preparations for indirect. So you address the emergencies, eliminate any anticipated or current source of pain, stabilize the occlusion, study your occlusion, the guidance, check the lateral movement. Is it a group function? Is it a canine guidance? How is the patient moving his jaw forward? Does he have any TMD, temporomandibular joint disorder? All of this is relevant. You have to know what you're dealing with. And next step in the sequencing, this is when you want to assess, do I have a hopeless tooth? Does it have a remaining tooth structure that will support my veneers or crown? Uh, does it have remaining periodontal support? Is it, how is the bone? How is the mobility? Endodontic status, how is it? Can I do the treatment, or I have to extract the tooth eventually? So why would I waste the patient's time? Overall importance of the tooth, is it important? Is it not? Of course, all teeth are important, but some teeth are crucial. Immediate or delayed implant placement, implant loading. This, of course, a big subject we cannot get into, but this is something you have to talk about. If you are planning to extract some teeth, you want to plan, am I doing an immediate implant placement after the extraction? Am I going to delay it? Do I have to do some bone grafting? Can I load? Do I have primary stability? Discuss this with the person who's doing the implant, your surgeon. The third is periodontal health. Eliminate the gingivitis, periodontitis, remove the calculus, help the patient with good oral hygiene. Do not jump into veneers if he's not cooperating with you. If you did any gingivectomy, wait 2 to 3 weeks until the gingiva is back to normal health. And if you did bone reduction with your gingivectomy, wait 6 weeks until the periodontal support matures. Treatment planning and sequencing. Endodontic restorations, note the preparation. Okay, guys, listen to this. When you're doing endo and you're removing the caries and you see the tooth is destroyed from the mesial, from the lingual, it has an undercut here. What are you going to do with it? Is it going to be a veneer? Do I need to put a post? Do I open the proximal contacts? Do I do it full crown for this tooth? Note these information now because you will forget them. There's no way you will remember 10 teeth, what they need when you're going to prepare them next visit. So note this in the patient's file. Okay, tooth number 11, I'm going to go with the lingual extension. Tooth number 12, I'm going to go full veneer, full crown, and so on. This should be, of course, guided by your remaining tooth structure. So what's remaining from the tooth will dictate how it will be covered with the indirect prosthesis. Then we schedule the preparation visit for indirect. Usually this takes 2 hours, 3 hours, depends. We're doing upper, lower, whatever. So this will be the topic, part 2. How do we do the mock? How do we put the mock-up on the tooth and the preparation? This concludes the outline of part 1, the end. So real quick, part 2, we will do it on 29 of April. 29 of April. This will give you like 5-6 days after Ramadan to adjust to the fasting, and hopefully the fasting is not going to be too hard on us during the quarantine, because eating is mostly what we're doing these days. So part 2, we will discuss how to take the shades, the shade of the tooth, the mock-up try-in that we talked about just now, some really nice tips, preparation and impression, and temporization. This is a nice topic for next visit. Hopefully, we will all get such nice results. Follow Dentsupply, Sirona, and follow me on Instagram. That's all.
Yeah, very nice. Thank you so
I
much.
don't hear any applause.
No, no, yeah, of course, because it's all silent. But really, you can see, you can read the chat. You can. It's really perfect. Thank you so much for the amazing webinar, the informative presentation, and it's very interesting topic. And the way you put in the very systematic, orientation
Hopefully, it was
is
easy to
perfect.
follow. Yeah, I wanted it to be
Exactly,
easy to follow.
exactly.
Yeah.
Let me go through this question that we have here. Before I start with the question, we this is like, yeah, as Doctor mentioned, is part one of three parts. So next, as Dr. Mohammed said, it's on 29th to continue with the topic.
29th,
And
10 o'clock, right?
yeah, 10
So it
o'clock
will be
p.m.
after iftar,
Yes,
after Taraweeh also. So
yes.
it will be nice.
Uh-huh. So um, let me start with the questions. Um, we will, yeah. If we have a patient who is a heavy smoker and coffee drinker, is bleaching an option?
Um, okay, if he's a heavy smoker, I tend to go for home bleaching more. And I also do the Profijet and the cleaning of the external uh, stains. Sometimes it will give you magical results because the smoking causes very easy to remove if you have the right tools, which is the Profijet. Any powder particle that is going on the tooth smoothly, it will remove all your outer surface external stains. But I tend to prefer home bleaching. Why? Because patient he's smoking constantly, right? So I don't want him to go for me, do this office bleaching, and then he will get nice results after 2 3 weeks he's smoking. It will go back. If he has a way to maintain that, I think I can serve the patient better.
Mhm. Thank you. There's a question here is like, a yellowish discoloration usually improve with normal bleaching,
Yeah.
while grayish discoloration is more sensitive to laser bleaching. Do you agree?
Usually the yellowish discoloration is originated from the coffee that we're drinking and the tea and those things. So it's not intrinsic. However, the grayish discolorations usually they are part of the tooth formation. So it's difficult to get such a huge result. But sometimes we succeed. Sometimes we get really nice results. So just try it. Just tell your patient, maybe it will not work. We can try it.
Mhm. You prefer for what do you prefer for home bleach, bicarbamide or the peroxide?
Hydrogen peroxide is actually carbamide peroxide, but carbamide peroxide turns into hydrogen peroxide, right? So home bleaching, we all use carbamide peroxide, and for the office bleaching, it's hydrogen peroxide. And hydrogen peroxide is much more concentrated, so we use it in higher concentration in the office, but it's really the same material. It transforms into hydrogen peroxide eventually.
Good. What type of band do you use to close the diastema?
Yeah, I get that question a lot on Instagram. There's no answer for this, guys. Sometimes I use a band that is, I don't have a photo of it, but it's an interior matrix teeth. It has, I don't know how to explain it to you, but you want the curvature of your matrix to be following the final outcome of what you want to achieve with that surface. So a conventional matrix designed for the posterior um, teeth is usually too convex. So what I do, either I do freehand buildup of one surface, and then I do the other surface while putting Teflon on the first composite. And sometimes I just bend the matrix that is too convex, just bend it so it will be straighter. Um, so there's a special matrix that I can send you the photos of it on, just contact me or something. I can send you the photo of it, but I don't have it now. And sometimes I do it freehand.
Hmm. Thank you, Doctor. So another one. Do you recommend index technique for composite?
Yes, and I use it a lot, especially if you have an existing composite you want to change. You just take that. It will give you support to do the buildup of the composite. It's very important. Sometimes you can take an alginate for a big case. Take an alginate, do the wax up, take putty of that wax up, and then you have an index, even though you don't have a previous restoration. And then you can cut that putty and put it on the tooth, trim it so it fits with your rubber dam, and then you just have a condensation medium lingually. After you finish condensation on the putty, just remove it. If you did your job well, if your isolation is good, your bonding technique is good, you should remove the putty and the shell will be still on the tooth. Quickly support it with more composite so it becomes stronger. And then check the lingual. You will see some irregularities. Cover them with flowable or anything.
Thank you, doctor. There's another question, which is, I guess it will, or you can decide maybe this time or next time. So please explain in details your technique. How do you do the palatal shelf for anterior filling step by step?
The palatal what?
Uh, Palatal shelf.
Yeah, palatal shift. It's basically the same question. I just answered that. How do you do it? Um, you do
Oh.
wax up putty, put it on the back, trim your putty, condense
Mhm.
composite, do of course your etching and everything, seal the composite that you don't want to do. Usually do one tooth at a time. It's easier to control, and you're good to go. Nothing to it.
Okay, a question here is, what do you use as a liner under a composite on posterior?
Mm, Not a relevant question, but there's a lot of liners out there. There's calcium hydroxide, there's biodentine, there is your self-etching and flowable composite. Just achieve good isolation, all right? And use whatever material you believe in. Personally, I don't really use liners that much. So if you want to follow that, you're welcome, because I want to seal the dentine. For me, this is the most important thing. So basically my liner is the flowable composite because it has such a nice interface with the dentine.
Good. There's a question about magnification, which is, can we replace magnification with dental loops? And another one about the what type or what brand of dental loops or adjustable dental loops
Good.
you recommend?
So what's the first question about the?
Can you replace, or can we replace the magnification? I believe it's like
Yes,
replace
I
or
had, yeah, I had a brand when I first started using magnification loops a couple of years ago. It's called Orange. It was 2.5, and then they released a 3.5 magnification. So I contacted the company. Okay, send us the loops. We will replace it for you. You pay a little bit of money, and then you have 3.5 instead of 2.5. I would suggest to start with 3.5 immediately because 2.5 is really not working anymore for me. Um, so the brand, we're not gonna discuss brands, just check, do your research, find a good company. Don't buy the knockoff brands because quality loops are your friend. I'm using them for maybe now 7 years. So really, it's worth the investment.
Good. What do you use for photography? Twin flash or ring flash or
All right,
black boxes?
I use this. I figured somebody will ask about the camera. I use this Sony A7R III, and I use a 90 millimeters macro lens. Any macro lens will work. Any camera will work. Even your mobile can work if you don't have a camera. You don't have equipment, just start. The equipment will come. Just
Mhm.
start with your mobile, then upgrade. So lighting, I use soft boxes and flash, normal flash. Sometimes I use twin flash. Just it depends what you're looking for. Soft boxes don't give you a lot of realistic photo. Flash, harsh lighting is much realistic. So I try to use them depending on the situation. And by the way, when I'm taking my shade guide photo, shade matching photos, I like to take them without any flash because I get a diffused natural light.
Good. There's a question about the what's the name of the ruler again that we have to Google it.
Just Google, it doesn't have a name. Google ruler, transparent, and then check, do you have good results? Change the search. If it's PNG, the format, the kind of file, if it's PNG, that means it supports transparency when you put it on the keynote. So it will not cover your teeth while you're trying to measure them. You can also lower the opacity of the ruler in the keynote if you don't find it. Just play with it.
Good. So do you follow the golden rule of to determine the incisal width of the teeth?
The golden ratio, he means
Ah,
the,
yeah.
the 0.682. No, I find it too narrow. It will give me very narrow teeth because imagine it's a 9.5 width for the centrals. And if you follow the golden rule, it will quickly be very narrow. Like um, suddenly your canine is 3 point something or so, or 4. So it doesn't work. Some patients have a small jaw, so I don't follow the golden ratio. I follow the RED, the recurring aesthetic dental proportion, depends on the patient's face.
Good. So digital smile design is software. Are you using it, or are you drawing on a Procreate?
Okay. I said in the lecture, I use Keynote and I use PowerPoint, and I can use whatever I want. I can use Photoshop. I can use any image manipulation software. The digital smile design protocol that we see, you have to buy it, equipment, stuff like that. It gives you a more streamlined experience. It will give you better results, of course. But what I'm trying to say is you can do your digital smile design with zero investment, and then you can upgrade.
Yeah. Is there any free programs or application for smile design?
That's
I
it.
think.
Keynote,
Mhm.
same, it's free.
Yes. Have you ever tried the mock-up doing it directly in the mouth
Mm,
using the additive reduction technique in your reps?
yeah. If you are going to change a lot of things in the smile, as I said, you can't really do it predictably directly on the mouth. Take an alginate, do it on your own time, wax up, learn waxing. It's fun, it's very important. It will enhance your composite skills as a dentist, and it will enhance you as an aesthetic dentist, of course. Sometimes, yeah, I do, I take a little bit of composite, I put here, dry the tooth. Don't really do any etching and any bonding. Maybe you can do a spot bonding if you want. Just tell the patient, okay, this is roughly how your teeth are gonna look like. Do you like where we're going? And sometimes I let them go with it. They leave the clinic, check it with their family. Yeah, I do it sometimes, but not the one that I'm going to use in my mock-up and the temporary work. And by the way, I don't always do wax up and mock-up. If I have existing ones, I just take putty of them and use them when I need, if I'm really not changing all that much in the smile.
Mhm. Thank you. How can we make wax up before starting prepare the teeth? Because sometimes teeth are crowded a little bit or inclined buccally.
Okay, good question. Sometimes you have crowded teeth, they will interfere with your final smile. So what do? Take alginate, prepare the cast as if you're preparing the tooth. Prepare all the teeth as you want them to be. Just go lightly because I'll tell you why later on. wax up, and then take putty. And then when the patient comes, show him the wax. This is what he gets. He cannot judge that smile on his tooth because we don't have additive. We're reducing from the tooth. So you tell him, okay, this is how your wax is turning out to be. If you want to start the treatment, we have to prepare from the teeth, and then after we have clearance for our putty, we can try the smile on your face. But we cannot do it before we reduce from the tooth, unless we go a little bit bulky, and then we can go inside. But that, yeah, minor detail.
Okay, many questions about the waiting time after the gingivectomy um, till the procedure. So
Yeah.
2-3 weeks or months.
Here, let's see. It's 2 to 3 weeks if you did only gingivectomy while respecting the biologic width. So 2 to 3 weeks is more than enough. Waiting 6 weeks if you did flap reduction, bone reduction, stuff like that. Okay, so if you intervened on the bone, the periodontal ligaments have need time to mature. So 6 weeks. Okay.
Good. Another question about the transferring from the SDS to wax up, the smile design application to
Okay.
wax up.
Okay. Here's two things. If you have a DSD, that's a 2D representation of your plan. You will copy it into a 3D representation, which is the cast. It will not be 100% the same. But as we said, you have the width, you have the height, you have the proportions. You know how much I want to remove from the left side, from the right side. So it's a rough, it's an informed estimate. Some programs and some CAD/CAM machines, you can do the smile design on the computer, and you can scan even the dentition, and then you do your design, and then you can mill it on a cast, and even you can even do a temporary from that. That's such a nice equipment to have, but again, it needs investment. So I'm trying to stay away from specialized machines, and I'm trying to teach you the concepts.
Okay, thank you. So do you place separating medium like Vaseline cream or on the teeth before place temporary crown or bridge?
Of course, you don't want your temporary material to stick to the composite or the tooth. So I put Vaseline, I put glycerin and light cure, basically anything that will make a separation in this so I can remove it. If it's just natural teeth and I'm doing a temporary veneer, I don't do Vaseline because I need the mechanical retention, because I really don't have anything to work with except the mechanical retention.
Good. Many questions about the if you have a case which is not very dark, not darker than A2, which bleaching would you recommend?
It's okay, you can go for whatever bleaching you want. I'm just saying, if your teeth if the patient's teeth are A2 or darker, you will really see nice results after the bleaching because it will be such a nice jump. Of course, we cannot predict everything, but that's what I'm seeing in my clinic. And if the patient has an A1 or BL4 tooth, really, what are you expecting to get? BL1? It will never happen. So that's my idea. And for my bleaching protocol, I tell the patient, okay, listen, do you want the results immediately? Office bleaching. Do you have the cooperation level to put the bleaching, home bleaching every day and get same results? Go for home bleaching, because home bleaching also gives you the ability to assess patients' cooperation with you. I see a lot of patients who I give them the home bleaching and then they disappear. They are not able to maintain this. Then they come after 6 months. They tell me, I really didn't really put the home bleaching. So that's when you know, okay, let's do office bleaching because you don't have the commitment level to do it. So it depends on your patient and when, how soon does he want the results.
Mhm. Thank you. Um, can we consider ceramic veneer as a treatment for upper anterior if the opposing lower teeth is BFM crowns? I guess this is later, can be more in details.
Can we consider veneers upper teeth if the lower?
If the lower
Yeah,
PFM.
yeah, why not? Sure. I don't see a problem.
Yes. Can we use biodentin without using composite?
No, no. Um, Biodentin is a material that is derived from MTA. It works on the dentine, and I really don't use it, by the way. But of course, you cannot use it without covering it with composite. Your enamel should be composite, bonded to composite only. And only the deep, deep sides of the dentine have to be lined. And sometimes I don't really line them.
Mm, thank you. So how long do cases take most of time for pictures and analysis to finish, or from pictures to finish? For pictures and analysis to finish?
The DSD, he means, maybe. The pictures.
Uh,
The pictures are immediate because I'm not using a filmic camera. I'm using a digital one. So I get the photos immediately. I'm sure that's not his question. I'm guessing how much time does it take me to do the DSD? Maybe, right? Um, I can do
I'm
it
not
in
sure actually.
three. I can do it in 3 hours, 2 hours, depending on the case. It takes some time because I check the aesthetic dental proportion. I check the, okay, I'm going away from the bounds of the teeth. So I have to dial it down a little bit. And then I dial it down, I see that my teeth are becoming narrow. So, okay, maybe I'll shorten my teeth a little bit. So it's a process to understand where you're going. It takes 2 to 3 hours.
Hmm. So another question: what type of composite you used for anterior and posterior?
We have a lot of options. You can use the composite that gives you dentine and enamel. What's the composite that you have in Dent Supply? Ceramics 1? No. Um,
Sphere Tech, yeah.
no, no. What is it?
Uh, ceramic Sphere Tech, yeah, one.
The dentine and the enamel and
No,
the.
no, that's ceramic duo. Ceramic duo. This is the duo. Yeah, it's called
So
duo.
that, so this one gives you, if you have a class 3 or a big buildup of the anterior tooth, if you put just a normal composite, it will show through cavity darkness inside. So you will get a grayish composite. So what we do is build up our shell, put the dentine in triangles. You don't want any rough edges. It's a really a different topic. I'm not going to go into it. Maybe we can cooperate with Dent Supply on another series. You want to use dentine, enamel, opalescence effects, something like that, to get close to the natural tooth.
Hmm. Thank you. Do you prefer lithium disilicate or feldspathic? And when do you use each?
Okay. Um, Emax, which is lithium disilicate, is a very good balance, has a good balance between physical properties and visual properties. It looks nice, it's relatively strong. Feldspathic is very nice, but it's weak, okay? So what happens now? We sometimes use just Emax fully, and it will look nice with some effects and some coloration and stuff like that with a really good lab technicians, such as my lab technician. But uh, the, let's say, standard of care now, if you want the most beautiful results, you have the build-up. What build-up? No, you have the core of Emax. That's your core veneer. And then your lab technician will use feldspathic to build up all the mamelons and the effects and the incisal enamel, and all of this. So you get the best of both worlds, strength from the Emax, and then you get the outer surface from Feldspathic.
Yes, thank you. There's a question here. One from one doctor is asking if we could show failed cases and how to avoid it. Maybe this is a topic. Um,
I don't have failed cases.
yeah.
No,
Good one.
no. How can we show failed cases?
Yeah, I know, but
No,
I'm thinking maybe
I
there's
will
difficulties.
listen. I'm not trying to just give you the beautiful cases. I want you to get something out of it. So of course we learn from our mistakes. So I'm gonna try to put that feedback into my next webinars. I'm gonna put some. I'm gonna try to search for the failing cases and put them. I'll try. I'll search.
It's like a good topic to to know about or to what to avoid maybe
Of
like
course, that
mishaps
by the way,
in any topic.
I'm planning this on part 3 after the cementation.
Okay,
Management
perfect.
of complications. This
Uh-huh.
I'm planning, but I don't know if I can fit it into this three series because I remember Dr. Hussam, who he told me I was really enjoying my quarantine time, sleeping, and then he told me, why don't we do
Uh,
something? And I really want to thank you guys for this opportunity to bring
uh,
all these dentists
thank you.
together, and really you're doing an amazing job. So he told me, okay, let's do a webinar. And then I started preparing my webinar, and then, okay, there's no way I can cover all these topics in 1 hour. So we decided to do them 3 parts. And maybe if we find there's a space, we will tell you about managing the complications and stuff like that. Sure, it's an
Yeah,
interesting.
there's good reason to stay tuned for the next series. I mean,
Yeah,
next. um, so another, do you use SDR as a liner?
yes, it's very good for that. Flowable composite gives you better adaptability with your dentine, and that's actually one of the teachings of Pascal Manier about this trending topic, immediate dentine sealing, and it's a big topic. But yes, SDR is very nice for using on the dentine directly.
Thank you. Another question: which size of soft box you use? Do you use?
I don't know the size, really. It's, can you see it's this big? Maybe 30, I don't know, 30, 40 centimeters. The size of the box, the soft box, doesn't really affect the final photo if you're shooting dental uh, teeth, because it's such a narrow field of view. But where do we need bigger soft boxes? If we don't want to really bother with directing our softbox completely well, and they use it for pictures of the whole body models and stuff like that, because it's they need more surface of exposure. That's why they get the higher, the bigger soft boxes. You don't really need to have the biggest soft box. It really takes a lot of space in your clinic and doesn't add a lot of value out of my experience.
Yes. Okay. Thank you. Do you know some custom-made templates about DSD?
I did my own templates.
Hmm. Good.
You really want to understand the process, and then you will find yourself with a template you will use all the time. If you don't understand the process, the template the template will not really help you that much.
Hmm. Thank you. Can we have maybe it's actually a request? Maybe next webinar, can we have a video of a veneer preparation for the next webinar? So
Yeah,
if it is
no,
possible.
no can do. Why? Because I only have 2 hands and I'm usually retracting, and preparing, and my nurse is doing everything else. So it really needs a special team to do the video. But I will try to illustrate everything very nicely, and photos will tell you everything. I can take photos easily, but I cannot prepare while doing a video. And I cannot, when you're preparing teeth, it's such a macro, couple of millimeters. So it's very, very difficult to shoot these kinds of videos because the field of focus is difficult to control. So no, I don't have a video of that.
Thank
Maybe we
you.
can do a hands-on
Later.
after
So,
after this pandemic.
yes. Yeah, hopefully soon.
Yes.
There's a question which is maybe something about you, something you mentioned is, can you please spell Kino app or
Keynote. Um,
Keynote? Huh?
um, how do we
It's,
spell
it's,
it?
it's, it's like the PowerPoint
I'll spell it.
of the Apple.
I have a nice way of spelling it. Wait a minute. All right, here it is. Keynote. Keynote. I don't know. Can you see it?
Mm-hmm. Keynote.
Keynote.
Very, very clear.
Key and note.
Yes. Key.
Key and note.
Okay. Thank you. How can you cement or bond temporary veneers?
You don't. The temporary veneers. This is part two.
Part
You
two.
you depend on the mechanical retention. It's
Okay.
a difficult thing to achieve. It's not. I'm not claiming that it's an easy thing. It's the most unpredictable thing to do, but it's really not that important if you don't have a deep preparation. So sometimes we go without it. And if I have a deep preparation, usually I have some sort of retention. So I put my putty, no bonding. Sometimes you do immediate dentine sealing, but that's a different topic. But you use the mechanical interlocking between proximal spaces so that your veneers will not go out. And it's a good idea to not make the patient wait for long before you give him the veneers.
Thank you so much. Last question here. Which you prefer for well-aligned teeth, veneer or lumineer?
Yeah, I don't really make a big distinction between veneers and lumineers. Veneers are lumineers. Lumineers are thin veneers, right? So if I can use, when can I use thin veneers? If my teeth are good in shade, so I don't really need to make a big shift in color, okay, that's a good indication for thin veneers. If my teeth are in good position, or after the preparation, they are in good position, so that's also a good indication for thin veneers. If you're still within the enamel layer, good for thin veneers. If you are deep within the dentine, sometimes you cannot really use very thin veneers because it will show through, and then you will get some discrepancy between this tooth and the next tooth because they are different in base stump shade color.
Great. I guess this is it. Thank you so much, Dr. Mohannad, for this amazing presentation. And inshallah, very soon for waiting for the next part. This was really amazing. And thank you all for attending the webinar. Um,
Thank
uh,
you.
Please, yeah, we will need your evaluation, of course. Yeah, this is perfect. And stay tuned. Next part will be on 29th of April, 10 p.m., 10 evening. All right. So you will receive also the invitation soon. Thank you so much. Have a nice evening. Bye. See you soon in the next part. Thank you, doctor.